Thank you for joining us. My name is Marcus Eskenazi with the Miami Kidney Group. I'm a nephrologist in South Florida. I've been in practice for approximately 20 years. I was asked by AFMED to create a presentation, a short presentation, to talk about the risk factors and the mortality associated with patients with renal disease, and hopefully with the idea to provide internists with information about the new guidelines as to when to refer patients to nephrologists. So if we start by looking at the overview of the presentation, we're going to talk about primarily epidemiology. We're going to talk a little bit about estimating renal function, the risk factors, disorders associated with low GFR. We're going to talk about the mortality associated with renal disease. And at the end, we'll talk about the guidelines for referral patients to a nephrology practice. So if we look at the world's population, the population in the planet is actually getting older, it's aging. If we look and compare, in 1950, approximately 145 million individuals were older than 65. In 2050, it is expected that we're going to have approximately 1.5 million individuals older than 65. To get an idea, in 1950, 5% of the population was older than 65. In 2050, about 16% of the population will be older than 65. Furthermore, there's a decline in the birth rate. Okay, so this rapid rise in the aging population, it's important because it's really mimicking what we're seeing in our nephrology practices. If we look at the prevalence of renal disease, you see that the prevalence is quite similar to what we see in the world's population. Individuals who are older than 65 up to and greater than 75 years of age have the higher prevalence of developing renal disease. As we talked at the prevalence, now we're looking at the incidence. In this slide, they compare the incidence of patients who, once they reach renal failure, they either go on dialysis or they obtain a kidney transplant. If we compare between 1950 to 2014, patients had an 86% incidence of going on dialysis, whereas in the same range of dates, there was only a 2% increase in patients who were able to obtain a transplant before going on dialysis. The reason for this happening is primarily because as patients get older, they have more comorbidities. It becomes more difficult to obtain transplants, and sometimes they're not eligible for a kidney transplant due to conditions such as significant heart disease or cardiomyopathies. Regardless, our goal is to try to hopefully reduce the incidence of end-stage renal disease and hopefully increase the incidence of more transplantation before they need to go on dialysis. All nephrology textbooks frequently stated that after the age of 40, there was a decline of a GFR of 10 mLs per minute per decade, which means that by the age of 80, your GFR would be approximately 60 mLs per minute. And this was commonly accepted. More recent data has really shown otherwise. In this study done in the BALTIMORE longitudinal study, they looked at different groups of patients, patients with no comorbidities, patients who have hypertension, and patients who have diabetes and proteinuria. And the ranges of patients in regards to age were between the age of 35 and 85. What they found was that those patients who had no comorbidities, there was really no change in GFR over time. So a patient could have the same GFR at the age of 35 and at the age of 70. Those patients that had hypertension actually had, over the years, a gradual drop in GFR. The patients who had diabetes with proteinuria were the ones who showed a more dramatic drop in GFR. So really, you don't necessarily lose GFR as you get older, but it has to do with the comorbidities you have, whether you have diabetes, whether you have high blood pressure, whether you have proteinuria. It is important to estimate or calculate the glomerular filtration rate. There's different methods. The most traditional one was to do a 24-hour collection to measure creatinine. The variables included urine creatinine, serum creatinine, and volume. And it would give you a very accurate measurement of GFR. Crocrow-Gold equation is also another measurement, usually primarily used by pharmacists. And the variables includes age, weight, and serum creatinine. Again, it gives you a fairly accurate measurement. The MDRD equation is probably the most popular formula now to measure GFR. The variables include serum creatinine, age, BUN, albumin, sex, and race. And again, this is very accurate in measuring GFR. You do have to be cautious when using this, specifically in the very young or the very old, because there may be some variations in accuracy. But for the most part, it's a fairly accurate way of measuring GFR. Cystatin C, it's less frequently used. It's more for pediatric nephrology. And the use of cystatin does not affect the patient's muscle mass, age, or sex. And this is done where you need very, very accurate estimation of the GFR. And again, it's more expensive and not frequently used. So if we look at two different individuals, both individuals have a serum creatinine of 1.6, and we calculate the GFR. The first individual is a 35-year-old male, African American, with a creatinine of 1.6, who has a GFR of 60 mL per minute. Second individual is an 85-year-old female, white, with a creatinine of 1.6, who has a 28.7 mL per minute GFR. You can see that both individuals have the same creatinine, yet they have a significant difference in GFR. This becomes quite relevant, especially when we want to address issues such as deciding whether a patient should have an intervention with the use of contrast, or whether we need to adjust medications based on GFR, such as anticoagulation or antibiotic therapy. If we look at the risk factors associated with renal disease, the major risk factors are older individuals, that is greater than 60, diabetes with proteinuria, hypertension, family history of diabetic nephropathy, non-Caucasians. There's other compounding factors such as obesity, smoking, hyperlipidemia, drugs, and medical intervention. If we look at the disorders associated with renal dysfunction, the most important ones include proteinuria, cardiac disease, left ventricular hypertrophy, hypertension, and anemia. And I will briefly touch on each one of those. Other comorbidities associated with advanced renal insufficiency includes high phosphorus, renal osteodystrophy, malnourished states, pericarditis, hyperlipidemia, hyperkalemia, metabolic acidosis, and a few other ones. So if we look at those five comorbidities, the first one is proteinuria. And in this graph, the point is to depict how patients who have microglinuria, that is between 50 to 299 milligrams per gram of protein, or patients who have macroglinuria greater than 300 milligrams per gram of protein, have a much higher mortality. You can see that regardless of the GFR, whether it's normal or between 15 to 60, those patients who have protein in the urine will have a higher mortality rate. So proteinuria becomes a quite important variable that we need to look at when we look at mortality, especially cardiovascular mortality in patients with renal disease. Anemia is another factor that plays a role in regards to determining mortality in patients with renal disease. In this slide, they look at patients who either have diabetes, CHF, CKD, and anemia, or in the combination of all of those. So if we look, patients who have diabetes and CKD, and we add anemia, their mortality changes from 2.4 to 3.6. If we look at patients who have CHF and CKD only, and we add anemia, their mortality jumps from 4.7 to 6. And in those patients who have diabetes, CHF, and CKD, and we add anemia, their mortality goes even higher from 6.3 to 7.3. So my point is that anemia is quite relevant in patients with renal disease. Anemia by itself will increase their mortality. Therefore, it's quite important to be aggressive in managing anemia by treating anemia with iron if necessary. In other words, if a patient has iron deficiency, we treat with iron. If the patient requires erythropoietin-stimulated agents, we use them. The point is trying to correct anemia. And the goal is not necessarily to bring the hemoglobin to 13, but try to keep the hemoglobin level between 10 to 11. Now, if we look at hypertension, hypertension is present in about 80% of patients who have renal disease. The result is due to excessive renal salt retention and increased peripheral resistance, both contributing to high blood pressure. Hypertension will accelerate the decline of renal function. Hypertension will develop left ventricular hypertrophy. It will exacerbate proteinuria, and more patients die usually before they reach end-stage renal disease with poorly controlled hypertension. ACE inhibitors and angiotensin receptor blockers are the preferred agents to be used in this group of individuals. So if we look at the prevalence of left ventricular hypertrophy, as I already stated, hypertension leads to LVH. So if we look at patients who have a GFR between 50 to 75, about 24% of them will have left ventricular hypertrophy. Patients who have a GFR between 25 to 50, about 32% of them will have a GFR of 32 mLs per minute. And patients who have a GFR less than 25 mLs per minute, about 42% of those will have left ventricular hypertrophy. Why is this important? This is important because when we look at the mortality, the cardiovascular mortality in the dialysis population, regardless of age, sex, or race, you can see that the mortality is much higher in the dialysis population compared to the general population. Now we're going to transition into the importance of early referral. Of all the slides, probably this is the most important one because this graph depicts what we have probably in every nephrology practice in this country. We find that patients who start dialysis in the hospital have a much higher mortality compared to those patients who start dialysis and are referred to the practice. Okay. If you look in the green line, patients who start in the practice will have anemia that is properly managed, high blood pressure, diabetes that will be well managed. And by the time they start dialysis, their mortality is lower than those patients who need to start dialysis in the hospital. Patients in the hospital usually will come in decompensated, frequently with CHF, anemia, malnourished state, where they almost certainly will start dialysis via total catheter and not a fistula. And therefore, clearly, if we can move towards starting patients and getting patients ready in the office, their mortality right off the bat is going to be much better. Referral to nephrologist. Patients should be referred to a nephrologist when their GFR is less than 40 mLs per minute. Early referrals have been associated with decreased mortality and morbidity, and subsequently leading to lower cost in healthcare. Usually, if a patient is referred to a nephrologist, it will be considered late referral if within 1 to 6 months that patient requires renal replacement therapy. Patients are frequently resistant to be referred to a nephrologist. The primary reason is fear of dialysis. Other causes include denial of their present renal disease, lack of appropriate understanding of their condition, fear of cost, and in some situations, patients desire to remain with their local clinician. If we look at the consequences of late referrals, we already briefly touched on them. We will see advanced metabolic disorders, anemia, difficult to control hypertension. These patients will frequently require sometimes up to 5 blood pressure medications, metabolic acidosis, secondary hyperparathyroidism, hyperkalemia, and a greater likelihood of prolonged hospitalization around the time of initiation of dialysis. As a result, ADMET has committed to helping channel patients to the proper specialist at the appropriate time. We frequently have conferences between vascular surgeon, nephrologists, and the ADMET nurses and staff to address issues and concerns that we have that may help expedite referrals and achieve better outcomes in our dialysis and renal failure population. A multidisciplinary approach requires the participation of internist, nephrologist, vascular surgeon, dietitian, dialysis educator, a social worker, and family support. And the combination of all these individuals or members will help reduce emergency dialysis initiation, prolonged hospitalizations, and more important, help reduce the incidence of dialysis catheters, which plays a very large factor in regards to comorbidities and complications at the start of dialysis. If we look at the referral guidelines, a patient should be referred to a nephrologist when the GFR is less than 40 mL per minute, when urine protein to creatinine ratio is greater than 1,000 milligrams per deciliter, when there is resistant hypertension, when there is progressive declining renal function, when there is electrolyte imbalances, autoimmune disorders such as lupus, nephrolithiasis, and acid-base disturbances. Pre-referral workup should include a CBC, a renal function panel, calcium and phosphorus levels, urine analysis with microscopy. You can either get a spot urine for protein and creatinine or a 24-hour urine collection for protein and creatinine, and a renal ultrasound. Pre-referral information. It will be important to have labs, at least 3 to 6 months of labs upon arrival to the office, list of current medications, list of known allergies, and progress notes so that we can expedite the evaluation of the patient. Appropriate planning for pre-dialysis patients. Have a rule, the 60-30-20-10 rule. If a patient has a GFR less than 60, it's really early renal insufficiency management where we need to educate our patients, assist them with proper management of diabetes and high blood pressure. If the GFR is less than 30, we want to start monitoring and treating new potential comorbidities such as anemia, hyperparathyroid state, acidosis. It is at this point where you start discussing transplantation or the different modalities of dialysis available. When the GFR is less than 20, you want to start implementing vascular access if it's appropriate and referral to transplant. When the GFR is less than 10, usually is the time when we start talking about starting up dialysis. So in summary, chronic renal insufficiency is associated with substantial morbidity and mortality, as well as financial impact. Aggressive control hypertension, diabetes, anemia, proteinuria, hyperlipidemia are key factors in helping improve the mortality and morbidity of our patients. So on my last slide, I want to emphasize team approach. We need to identify and screen the population at risk. We need to do from day-to-day management of patients with early renal insufficiency by reducing or treating cardiovascular risk factors such as hyperlipidemia. We need to monitor and treat more aggressively diabetes, hypertension, and anemia. You need to work with your nephrologist to help slow down the progression of renal disease. And you also want to work with your nephrologist in the preparation for dialysis or transplantation. I would like to thank you for taking the time to listen to this presentation. I hope it was helpful. And always feel free to contact your local nephrologist if you have any questions in regards to individuals or patients who may require more immediate assistance. Thank you again. You have a good day.